This is MorbiCast, your quick dive into the world of medicine.
Imagine this. You are 28 years old, you are in your second trimester of your first pregnancy, and, you just got back from what was supposed to be the perfect, relaxing baby moon.
Right, 2 weeks on a beautiful tropical beach.
Exactly. Soaking up the sun before your entire life changes. But then, 2 days after you unpack your suitcase, your joints start to ache.
No.
Yeah, a flat, red, bumpy rash starts creeping down your arms and across your torso. Your eyes get bright red, really irritated.
And naturally, you pull out your phone to search for what's going on.
Right, and the news is showing these just terrifying images of a microscopic pathogen causing catastrophic, irreversible birth defects in the exact town you just visited.
I mean, it is the ultimate nightmare scenario for an expectant parent.
Totally.
That transition from pure anticipation to just absolute terror in a matter of hours.
Yeah, you rush into the clinic and you're sitting on that crinkly paper on the exam table just radiating anxiety. Okay, let's unpack this, because this is the exact clinical scenario we're using today to anchor our deep dive.
It's a heavy one.
It really is. We are diving into a comprehensive clinical breakdown of a pathogen that completely upended the global health landscape just a few years ago, which is, of course, the Zika virus.
Right.
And whether you are a medical student cramming for your infectious disease boards, or a clinician looking for a refresher, or just someone trying to understand how global health threats actually operate biologically, we're going to give you a masterclass today.
Yeah, we're really getting into the weeds on the clinical, biological, and public health realities here.
Absolutely, because we want to show you how a virus survives, spreads, and infiltrates the human body.
And we really have to start right there in that exam room. Because that tension you just described, that is what makes this specific virus so critical to understand. I mean, when a pregnant patient presents with a low-grade fever, that maculopapular rash...
Because it's just a mix of flat, red patches and raised bumps, right?
Exactly, along with joint pain and non-purulent conjunctivitis, so red eyes without any pus.
Right, got it.
And they have a travel history to an endemic zone. The entire temperature of the clinic changes.
Because if I'm the doctor in that room, I can't just say, take some Tylenol, it's a bug.
No, absolutely not.
The word Zika, next to the word pregnancy, demands immediate action. So to really grasp what this pregnant patient is facing, I want to back all the way up. Let's look at the specific enemy she might have brought back in her bloodstream.
Put the culprit under the microscope, so to speak.
Exactly. Where did this thing even come from? Because, if I remember the news cycle from 2015, it felt like this virus just materialized out of thin air, like some brand new sci-fi mutation.
It definitely felt that way to the general public, but scientifically that couldn't be further from the truth. Zika actually has a surprisingly long caper trail.
Really?
Yeah, it was first isolated way back in 1947.
Wait, 1947, we've known about this for over 70 years.
Yes, and the story of its discovery is a classic example of scientific serendipity. Researchers were working in the Zika forest in Uganda.
Which I'm guessing is where the name comes from?
Exactly. But they weren't looking for a new virus. They were actually deep into researching yellow fever.
Oh, interesting.
Right, so to do this, they set up these sentinel cages up in the forest canopy holding rhesus macaque monkeys.
Okay, so the monkeys were basically biological tripwires.
That's a great way to put it. They were waiting to see if mosquitoes in the canopy would infect the monkeys with yellow fever. One of these monkeys developed a fever, but when they took a blood sample and isolated the transmissible agent, it wasn't yellow fever.
Let me guess. It was our culprit.
It was an entirely distinct, previously unknown virus. They named it Zika. And they found the first human cases just a few years later, around 1952, in Uganda and Tanzania.
Okay, that kind of blows my mind. If we found this in 1947 and documented human infection in 52, why did it just sit in the dark until 2015? Was the scientific community just asleep at the wheel? Did we ignore it because it was localized in Africa?
It wasn't necessarily negligence. It was more a matter of clinical triage. For decades, Zika was considered a virological non-entity.
A non-entity.
Yeah. When it did infect humans, it circulated sporadically across parts of Africa and Asia, but it primarily caused very mild self-limiting illness. A slight fever, maybe a rash, and then you were fine.
So it just wasn't a priority.
Exactly. If you're a tropical medicine researcher in the mid-20th century and you're surrounded by massive killers like malaria, yellow fever, and dengue, You simply aren't going to spend your limited grant money studying a virus that basically causes a mild cold.
It was literally just a footnote in textbooks.
Pretty much, yeah.
Okay, that makes a dark kind of sense. It was ignored because it wasn't killing anyone, so when did it actually start flexing its muscles then?
We started seeing the first shifts in 2007. There was a major outbreak on Yap Island in Micronesia.
Micronesia, that's quite a jump.
It was a huge red flag because the first time we saw it spread explosively in a human population outside its historical geographical boundaries. Then it island hopped across the Pacific to French Polynesia in 2013, where it caused a massive outbreak.
Wow.
And finally, it made landfall in the Americas, erupting in Brazil in 2015.
Okay, so let's dig into the biology of this thing. If I'm looking at its genetic ID card, what are we dealing with here? I know it's an arthropod-borne virus, an arbovirus, meaning it's carried by bugs.
Right.
But specifically, the sources say it belongs to the Flaviviridae family, genus Flavivirus. Talk to me about the Flavivirus family. What does that mean structurally?
Well, the family grouping is incredibly important because it dictates the virus's blueprint. Flaviviruses are enveloped, positive sense, single-stranded RNA viruses.
Okay, hold on. I'm going to need you to translate that into English for me. Let's start with enveloped. I just picture a virus wearing a tiny winter coat.
You know, that's actually not far off. An enveloped virus means that its outermost layer is a lipid membrane, so a layer of fats.
Okay, a fat coat.
But here is the fascinating part. The virus doesn't make that membrane itself. When the virus replicates inside a human host cell and is ready to leave, it literally pushes its way out of the cell and steals a piece of the human cell's own membrane, wrapping itself in it like a cloak.
Wait, a cloak of invisibility made from our own cells? That is incredibly devious.
It really is. It helps camouflage the virus from the immune system initially. But that stolen coat is also a major structural weakness.
How so?
Lipid envelopes are very fragile. They're easily destroyed by things like soap, alcohol, hand sanitizer, or even just drying out in the sun. That's why viruses like Zika, or even SARS-CoV-2, which is also enveloped, don't survive long on surfaces like doorknobs or countertops.
Oh, got it. So the winter coat is stolen but flimsy. What about the positive sense, single-stranded RNA part?
That describes the virus's genetic payload. You see, our human DNA is double-stranded and has to go through a complex transcription process before our cells can read it to build proteins.
Right, there's a whole translation step.
Exactly. But Zika's genetic code is positive sense RNA. That means its code is already fully formatted and ready to go. Yeah, the second Zika breaches a human cell and drops its RNA payload. The human cell's own manufacturing machinery, the ribosomes, grab that RNA and immediately start reading it. The human cell gets hijacked instantly and starts churning out viral proteins before it even realizes it's under attack.
So it doesn't even need to translate the instructions. It just hands our cells a blueprint and our cells blindly build the enemy army.
That's exactly how it works.
Man. You know, I always look at this Flavivirus family tree like a lineup of usual suspects in a police precinct. You look through the glass and you see some really nasty global troublemakers standing there.
You really do. Dengue virus, yellow fever virus, West Nile virus, Japanese encephalitis virus, they're all genetically related flaviruses.
Right.
They share that same stolen envelope structure, that same positive sense RNA, and they usually share the same getaway vehicles mosquito.
Oh, right. But dengue causes bone-breaking fever and hemorrhage. Yellow fever liquefies your liver. For decades, Zika was the mild-mannered cousin in this crime family. What did we learn in 2015 that changed its rap sheet so drastically?
Right. What is its unique angle?
Exactly.
What shocked the global health community and what makes Zika so profoundly unique among its relatives is its unprecedented ability to cross specific biological barriers that most other flaviviruses simply bounce off of.
Okay, like what barriers?
Well, Zika somehow evolved the biochemical keys to cross the placental barrier to infect a developing fetus. And it learned to cross into immune-privileged compartments, specifically the testes, allowing for sexual transmission.
Wow. West Nile doesn't do that. Dengue doesn't do that.
Nope. That barrier crossing capability is Zika's unique and devastating signature.
Which brings us back to the most pressing question for our pregnant patient sitting in the clinic. How did this virus actually get inside her? And looking at the macro level, how did it conquer the Americas so fast?
Let's talk about the pathways of invasion.
Yeah, the obvious one, the primary vector, is the mosquito. But it's not just any mosquito that happens to be buzzing around a swamp.
No, it's highly specific. The vast majority of global transmission is driven by infected mosquitoes of the Aedes genus, specifically Aedes aegypti, and to a slightly lesser extent, Aedes albopictus.
So if I'm on a camping trip in the deep woods and a mosquito bites me at dusk, is that the guy I have to worry about for Zika?
Almost certainly not. Those are usually Culex or Anopheles mosquitoes. The Aedes aegypti mosquito is what we call highly anthropophilic.
Meaning?
Well, anthropo meaning human, philic meaning loving. They don't want to live in a deep forest or a swamp. They have evolved alongside human civilization. They prefer to live directly inside and around human dwellings, particularly in crowded urban environments.
So they are basically urbanized pests. They want to be right in our backyards.
Exactly. And their breeding habits make them incredibly difficult to eradicate. They don't need a large pond to lay eggs. They can breed in a tablespoon of stagnant water.
Wait, really? A tablespoon?
Yeah, a discarded tire in a vacant lot that catches rainwater, an empty flower pot on a balcony, even a plastic bottle cap thrown in the gutter.
That is insane.
It is. And the most crucial difference regarding human behavior, they are aggressive daytime biters.
Wait, daytime. So you aren't safe just staying indoors at night with a mosquito net?
No. They actively hunt during peak daylight hours, especially early morning and late afternoon. So going back to our clinical scenario, our pregnant patient on her baby moon wasn't necessarily bitten sleeping in a jungle hut at midnight.
Right.
She was likely bitten while walking through a sunny, bustling town square at 2 in the afternoon or while having lunch on a restaurant patio.
Wow. That drastically changes how you have to think about prevention. But here's where the transmission profile gets genuinely bizarre to me.
Okay.
A mosquito-borne virus that can also be sexually transmitted. Is that kind of crossover normal in virology? Because to my mind, an insect-borne disease stays an insect-borne disease.
It is a massive anomaly. When the data first started emerging that Zika could be transmitted through sexual contact, it was a complete paradigm shift for the infectious disease community.
I can imagine.
Typically, an arbovirus absolutely requires the insect to complete its life cycle. It has to incubate in the mosquito's gut, replicate in its salivary glands, and then be injected into the next human.
Right. I get bitten, the mosquito acts as the bridge and then bites you. Without the mosquito, the chain is broken.
That's the established rule. But Zika found a backdoor. When a male patient is infected with Zika, the virus travels through the bloodstream and can physically sequester itself inside the testes.
Okay.
The testes, along with the brain and the eyes, are what we call immune-privileged sites.
Immune privilege. What does that actually mean? The immune system just ignores them.
Basically, yes. It's an incredible evolutionary adaptation. Sperm cells are constantly dividing and look very different from other cells in a man's body. If the immune system were allowed free rein in the testes, the body's own white blood cells would likely identify the sperm as foreign invaders and destroy them.
Oh, rendering the man sterile?
Exactly. So over millions of years of evolution, the body put up a biological fence around the testes. The immune system's heavy artillery is largely barred from entering.
Oh, wow. So the body creates a safe house for reproduction, and the Zika virus essentially picks the lock, walks into the safe house, and realizes the cops can't follow it inside.
That is a perfect analogy. The immune system clears the Zika virus out of the bloodstream, the liver, the skin, usually within a week or two. The patient feels totally fine.
Right.
But the virus is still quietly replicating inside the testes, completely shielded. Because of this, the virus can remain viable in human semen for an astonishingly long time. We are talking months after the initial infection.
That is terrifying. So a man could go on vacation, get a mild fever, recover completely, and then 3 months later, entirely asymptomatic, pass a devastating virus to his pregnant partner through sexual contact.
Yes, and obviously if that partner is pregnant, the consequences can be catastrophic. Which brings us to the third and most critical route of transmission, vertical transmission, mother to fetus.
Now, normally, the placenta acts as a biological fortress, right? It
Right.
filters nutrients and oxygen, but keeps out the bad stuff. How does a flavirus like Zika punch through that wall?
Well, it doesn't punch through, it tricks the guards. The placenta is indeed a formidable barrier, covered in specialized cells called trophoblasts. Most viruses simply cannot infect these cells.
But Zika can.
Right. Zika has specific proteins on its viral envelope, that winter coat we talked about, that happen to perfectly bind to receptors on the surface of these placental cells.
Man.
It uses the cells of the placenta as a stepping stone. It infects the barrier itself, replicates inside it, and then sheds newly formed viruses directly into the fetal bloodstream. And this can happen at any stage of the pregnancy in any trimester.
I know there are also some rare, almost mechanical routes of transmission documented in the sources. Blood transfusions, right?
Correct. During the acute phase of the illness, the virus causes viremia, meaning it is actively circulating in high concentrations in the blood. If a patient is asymptomatic and donates blood during that specific window, the infected blood can be given to a recipient. During the massive 2015-2016 epidemic, this became a major crisis.
I bet. They must have had to scramble.
Blood donation centers across the Americas had to rapidly implement entirely new screening and nucleic acid testing protocols just to protect the regional blood supply. There are also documented, though exceedingly rare, cases of transmission via organ transplantation and accidental laboratory exposure.
Okay, let's zoom out to the epidemiology for a second. You brought up the 2015 epidemic. I really want to understand the mechanics of how it exploded so fast. If it was a mild virus in Africa for 70 years, why did it suddenly look like a tidal wave when it hit Brazil?
Epidemiologists refer to it as the alignment of a perfect storm. It was three distinct critical factors converging all at once.
Okay, what were they?
First, you have to consider the host population. When Zika arrived in the Americas, it landed in a population of hundreds of millions of people who were entirely 100% immunologically naive.
Meaning no one had any antibodies. The immune system had never seen this before, so there was zero defense.
Exactly. In Africa, the virus had been circulating at low levels for generations. So many people caught it as kids, got mildly sick, and developed lifelong immunity.
Ah, okay.
In Brazil, it was a totally blank slate. Second, the virus landed in a country with massive, densely populated urban centers. And third, those urban centers were already deeply infested with our anthropophilic friend, the Aedes aegypti mosquito.
So the ideal vector meets the ideal unprotected host in incredibly tight quarters.
It was essentially dropping a match into a dry forest. The virus spread with staggering speed. We're talking millions of human infections across the Americas in a matter of months.
Millions.
Yeah. And this sheer, terrifying scale is actually what finally revealed the virus's true, devastating nature.
Because it's a numbers game, right?
Precisely. If a virus causes a severe complication in only 1 out of every 10,000 infections, and it only infects 500 people in a rural village over 5 years, that complication might never happen.
Or if it does, it's just written off as a tragic, isolated anomaly.
Right. But when that same virus infects 3 million people in a single year, suddenly, that 1 in 10,000 complication is happening to 300 different people.
And suddenly you have pediatric neurology wards filling up simultaneously across entire cities.
Exactly. The virus couldn't hide its rare complications anymore because the sheer volume of infections forced it out into the open.
So where does Zika stand globally today? Are we still seeing that tidal wave?
No, the tidal wave has receded, and that's largely due to that same concept of immunity.
Oh, because it burned through everyone.
Yes. The explosive spread in 2015 and 2016 burned through the susceptible population so fast that it's essentially created a massive wall of herd immunity. The virus couldn't easily find new hosts, so the massive outbreak collapsed.
Okay, well, that's good news, at least.
It is. But however, the current geographic distribution of the virus mirrors the habitat of the Aedes mosquito, which covers vast swaths of the global tropics and subtropics. Today, Zika is considered endemic in many of these regions.
Endemic, meaning it's just a permanent part of the landscape now? It circulates at a low, persistent baseline level.
Right. But the public health threat remains severe because you constantly have travelers, like our pregnant patient, who have absolutely zero immunity flying into these endemic zones every day.
Yeah.
Furthermore, as time passes, new generations of children are born in those endemic areas who haven't been exposed. The pool of susceptible individuals slowly fills back up. It is a cyclical threat waiting for the next spark.
Let's track that spark directly into the body. Let's go back to our patient. The Aedes aegypti mosquito lands on her arm in the town square. What happens in the first 60 seconds? We know the virus gets in, but how does it breach the wall? What is the inside story on pathogenesis?
Let's follow the timeline literally from the moment of the bite.
Yeah.
The Aedes mosquito pierces the epidermis with its proboscis. Now, if it just sucked blood, the human body would react instantly. Blood would clot, and it would hurt.
Right, you'd swat it.
Exactly. So the mosquito immediately injects its own saliva. This saliva is a complex biological cocktail. It contains anticoagulants to keep the blood flowing freely and local anesthetics so the human doesn't feel the bite and swat the bug away.
Clever.
And unfortunately, riding along in that saliva is the Zika virus.
So the virus is injected directly into the skin tissue, but the skin isn't just a physical wrapper. It's heavily guarded by the immune system.
Highly guarded. The skin is packed with specialized immune sentinels, primarily dendritic cells and keratinocytes.
If I'm visualizing this, dendritic cells are like the border patrol scouts, right? They wander around the skin looking for foreign invaders to capture.
That's their exact job.
Yeah.
They're supposed to capture an antigen, a piece of the virus, and then physically travel to the nearest lymph node to show the antigen to the T cells and B cells, essentially sounding the alarm to activate the heavy immune response.
Okay.
But Zika is incredibly insidious. It actually targets and infects those very dendritic cells.
Wait, it infects the security guards.
It infects them, replicates inside them, and then lets the dendritic cell carry out its normal biological imperative. The infected dendritic cell migrates to the local lymph node to sound the alarm, but it's acting as a biological Trojan horse.
Oh my God.
Yeah, it carries the actively replicating virus right into the heart of the lymphatic system.
That is diabolical. It hitches a ride on the exact alarm system designed to destroy it and gets dropped off right at the command center.
Exactly. Once inside the lymph nodes, the viral replication goes into overdrive. From the lymph nodes, it spills over massively into the bloodstream. This is the viremia phase.
The highway system.
Right. Now, the virus has the highway system it needs to access the entire body. The human immune system, realizing it has been breached, finally mounts a massive systemic response. It releases a flood of inflammatory cytokines, activates killer T cells to hunt down infected tissue, and ramps up B cells to start custom manufacturing neutralizing antibodies.
And this massive physiological warfare is what is actually causing the symptoms our patient is feeling.
Precisely. That is a crucial concept in infectious disease. The low-grade fever, the throbbing joint pain, that maculopapular rash on her torso, those symptoms are rarely caused by the virus itself destroying skin or joint cells.
Really?
Yeah, they are the collateral damage of the host's own massive systemic inflammatory immune response trying to boil the virus out of the system.
Wow. But the clinical breakdown emphasizes a very specific, chilling characteristic of Zika's battle plan once it gets past those initial defenses, a term we keep coming back to, neurotropism.
Yeah, neurotropism.
Let's break that down. Tropism means an affinity or preference for something, so this virus prefers the nervous system.
It does. While it infects skin and lymph tissue to gain entry, its ultimate biological affinity, where it truly thrives, is inside nervous tissue. Its surface proteins allow it to latch onto and enter neural cells. But it's even more granular than that. Zika has a profound, highly specific preference for infecting neural progenitor cells.
Progenitor cells, meaning the ancestors of other cells, like stem cells.
Functionally, very similar. Neural progenitor cells are the early, undifferentiated cells in a developing brain. They are the raw material. They aggressively divide and eventually mature into fully functioning neurons, astrocytes, and glial cells. They are literally the scaffolding and the bricks that build the brain.
Okay, let me rethink the analogy here. Earlier we talked about the virus targeting things, and it's easy to picture a guided missile locking onto the nervous system. But a virus doesn't have a navigation computer. It's blind.
Right, it doesn't know where it's going.
It's more like a virus wandering blindly down a massive hallway lined with millions of doors. It tries every single doorknob it bumps into. Most of them are locked. But when it bumps into a neural progenitor cell, it just happens to have the exact master key in its pocket.
That is a much more accurate biological metaphor. The virus just circulates until it physically collides with a cell it has the key for.
So let me ask you this. For a healthy, non-pregnant adult who gets infected, say the husband of our patient, he has a mature nervous system. Is the mild rash and the fever just a smokescreen for the virus trying to ravage his brain?
It's a matter of biological maturity. In a fully developed adult, the brain is almost entirely composed of mature, fully differentiated neurons.
Okay.
The virus doesn't have the key for mature neurons. It only has the key for the progenitor cells, which adults have very few of. Furthermore, the adult brain is shielded by a thick, fully formed blood-brain barrier.
So it can't even get in easily.
Right. So when an adult gets Zika, the virus wanders the hallway, tries the doors, finds them mostly locked, and eventually the systemic immune response clears the virus out before it can do any real neurological damage.
And that explains why the clinical data says the infection is completely asymptomatic in up to 80% of adult cases.
Yes. 4 out of 5 people who contract the Zika virus never even know they had it. Their immune system handles it quietly.
80% asymptomatic is a staggering statistic. But for the 20% who do get sick, we're looking at that standard symptom profile.
Right. The rash, fever, and joint pain. And even for that 20%, the standard disease course is mild and self-limiting. The symptoms peak over a few days and generally resolve within a week. The prognosis for a healthy adult is excellent. You rest, stay hydrated, and you recover without any long-term consequences.
But the stakes warp entirely when we introduce a developing fetus into the equation. That neurotropism, that master key for neural progenitor cells, changes everything.
It really does.
The mild physical symptoms our pregnant patient is experiencing are completely disconnected from the absolute catastrophe happening at a cellular level across the placental barrier. This leads us into what is undeniably the darkest and most critical part of this clinical breakdown, the complications.
When clinicians talk about the severe complications of the Zika virus, we divide them into two distinct phenomenons. There's the catastrophic effects on the developing fetus and a rare, severe neurological complication that can affect adults.
Let's start with the fetal outcomes, which fall under the umbrella diagnosis of congenital Zika syndrome, or CZS.
Yes. And the most visually striking, infamous hallmark of CZS, the one that dominated the news in 2015, is microcephaly.
Right. Microcephaly literally translates to small head. But to understand the true pathology, we have to connect it back to those neural progenitor cells, don't we?
Exactly. When the Zika virus crosses the placenta and breaches the fetal brain, it encounters a paradise. A developing fetal brain is essentially made entirely of rapidly dividing neural progenitor cells.
Oh, wow.
The virus has found an endless supply of doors it has the master key for. It infects them, hijacks their machinery to furiously replicate, and inevitably induces cell death. It massacres the progenitor cells.
So to clarify the physical mechanism here, and this is a tough question to ask, is the virus physically halting the ongoing construction of the baby's brain, or is it actively destroying the brain tissue that has already been built?
Tragically, the cellular mechanism results in both. But the primary driver of the microcephaly is the halting of construction. By systematically killing off the progenitor cells, the virus removes the scaffolding and the raw materials needed for the brain to expand. The brain literally ceases to grow.
That's awful.
It is. The reason the infant is born with a disproportionately small head isn't because the virus attacks bone cells. The human skull grows in direct response to the physical pressure of the expanding brain pushing outward against it. If the brain doesn't grow and exert that pressure, the cranial bones collapse inward on themselves.
That is horrific. The skull essentially folds in because there's no pressure keeping it inflated.
Exactly. When these babies are born, clinicians often observe overlapping cranial sutures. The plates of the skull actually slide over one another because the cavity is too small.
But the clinical breakdown makes it clear that congenital Zika syndrome is far more extensive than just the size of the head. Microcephaly is just the most visible symptom of a broader systemic destruction.
Correct. CZS represents a spectrum of profound neurological anomalies. Because the brain tissue isn't just failing to grow, but is actively being destroyed by the virus and the resulting localized inflammation, we see physical scarring inside the brain.
Like scar tissue.
Specifically, subcortical calcifications. These are literal deposits of calcium that form over areas of dead brain tissue. You can see them brightly on an MRI. Furthermore, the cerebral cortex, the outer layer of the brain responsible for higher-level thought, motor function, and sensory processing, is often radically thinned out and malformed.
And this neurological damage cascades into the rest of the body's development, right?
It cascades severely. These infants frequently present with severe ocular anomalies. The virus attacks the back of the eye, causing macular scarring and retinal damage, often leading to partial or complete blindness. We also see congenital contractures, most commonly presenting as clubfoot.
Wait, how does a brain virus cause clubfoot?
It's a secondary mechanical failure. During healthy fetal development, the brain sends constant electrical signals to the muscles, causing the fetus to kick and move its limbs. Right.
This movement is essential for the joints to form flexibly. Because the Zika-infected brain is so severely damaged, it fails to send those motor signals. The fetus remains largely immobile in the womb, and as a result, the joints freeze and fuse in abnormal positions.
That is it's a cascade of systemic failures from one microscopic invader. What are the long-term clinical outcomes for children born with severe CZS?
They face a lifetime of profound challenges. These children generally have severe intellectual and cognitive disabilities. They often suffer from intractable, hard-to-manage epileptic seizures.
That's heartbreaking.
Many have profound dysphagia, difficulty swallowing, which necessitates permanent feeding tubes directly into the stomach to prevent them from inhaling their food and getting pneumonia. They require round-the-clock, intense, multidisciplinary medical, physical, and occupational therapy just to survive. It is an unimaginably heavy burden for the families and the healthcare system. But the virus's neurological complications aren't solely restricted to the unborn. The clinical text outlines a very specific, severe complication that can strike adults, including patients who aren't pregnant, Guillain-Barré syndrome.
Yes, Guillain-Barré syndrome, commonly referred to as GBS. This is a rare but intensely life-threatening neurological condition. But unlike microcephaly, where the virus directly destroys the tissue, GBS is an autoimmune phenomenon.
Autoimmune.
Right. The body's own immune system makes a catastrophic error and attacks the patient's peripheral nervous system.
How does a viral infection trigger a mutiny like that? Why does the immune system suddenly turn its weapons on its own body?
The most widely accepted pathophysiological theory is a concept called molecular mimicry. Let's walk through it.
Okay, let's hear it.
When the Zika virus infects an adult, the immune system eventually ramps up B cells to manufacture specific antibodies. These antibodies are custom designed to recognize and latch onto the specific protein shapes on the surface of the Zika virus.
Right. They are basically custom-molded puzzle pieces designed to fit only the Zika virus.
Exactly. But biology is messy. It turns out that some of the protein structures on the surface of the Zika virus happen to look structurally almost identical to the proteins found on the myelin sheath in the human body.
The myelin sheath, that's the protective coating around our nerves, right? Like the rubber insulation wrapped around a copper electrical wire.
That's a perfect analogy. The myelin sheath insulates the peripheral nerves and allows electrical signals to travel at high speeds from the brain to the muscles. So what happens in molecular mimicry?
The immune system gets confused.
Yes. The patient's immune system successfully defeats the Zika virus. The patient feels fine. But those custom-built Zika antibodies are still circulating in the bloodstream on patrol. They bump into the myelin sheath of a peripheral nerve, look at the proteins and say, aha, that looks just like Zika. It's a tragic case of mistaken cellular identity.
So the antibodies call in the immune artillery to attack the patient's own nerve insulation.
Yes. The immune system violently strips the myelin insulation off the peripheral nerves. When you strip the insulation off a wire, the electrical signal shorts out. It disrupts the motor signals traveling from the brain to the muscles. Clinically, this presents as ascending symmetrical paralysis.
Ascending meaning it starts at the bottom and climbs.
Correct. The patient will typically notice tingling, numbness, or profound weakness in their toes and feet. Over a period of hours or days, that paralysis creeps upward into the legs, the torso, and the arms.
And the ultimate danger is when that creeping paralysis hits the chest.
Exactly. The greatest clinical emergency in GBS is when the paralysis ascends high enough to reach the diaphragm and the intercostal muscles of the chest. Once those muscles are paralyzed, the patient physically cannot draw a breath on their own. They will suffocate.
Oh my goodness.
These patients must be urgently intubated and placed on mechanical ventilation in an intensive care unit.
And how long does that last? Does the paralysis recede?
It does, but slowly. They remain on the ventilator until the immune system eventually calms down and stops the attack, and the peripheral nerves slowly regenerate their myelin sheath. But nerve regeneration is agonizingly slow. Recovery can take weeks, months, or in severe cases, years, and often involves grueling physical rehabilitation to regain muscle strength.
Okay, so let's snap back to our clinic room. The stakes could not be higher. We have a pregnant patient sitting in front of us, absolutely terrified of congenital Zika syndrome, and we know that even as an adult, she has a small but real risk of developing Guillain-Barré in the coming weeks. The absolute, undeniable, most immediate priority in that room is getting a definitive answer.
Absolutely.
We have to solve the diagnostic puzzle. How do we actually test for Zika? Because if my medical knowledge is accurate, testing for flaviviruses is notoriously tricky.
It is incredibly tricky. Diagnosing Zika requires a combination of astute clinical suspicion and highly specialized laboratory assays. The clinical suspicion part is the trigger. In our scenario, the physician's radar is already blaring because the patient has the classic constellation of symptoms: rash, fever, joint pain, red eyes, combined with a verified travel history to a known endemic area. That history immediately dictates which laboratory pathways we go down.
The clinical breakdown outlines two distinct avenues of laboratory testing: nucleic acid amplification tests, specifically PCR and serology. Let's start with PCR. If I remember basic biology, PCR is what we used a lot during COVID. What is it actually doing?
PCR stands for a polymerase chain reaction. And because Zika is an RNA virus, we use a specific variant called reverse transcriptase PCR, or RT-PCR, To use a detective metaphor, PCR is not looking for circumstantial evidence. It is looking for the physical, biological fingerprints of the killer at the scene of the crime.
Oh, okay.
The lab takes the patient's blood serum, uses chemicals to break open any viruses present, extracts the raw genetic RNA, and then runs it through a machine that amplifies it. It looks specifically for the Zika virus's unique genetic code.
So if a PCR test comes back positive, there's absolutely zero doubt. The virus is actively physically present in her blood.
Exactly. RT-PCR is incredibly highly specific. A positive result is a definitive confirmation. However, the PCR test has a massive, glaring vulnerability: timing.
Why is timing an issue?
Because the Zika virus is only present in the bloodstream in high enough concentrations to be detected, the viremia phase, for a very, very short window. Typically, it's only detectable in the blood for the first 3 to 7 days after the onset of symptoms.
Really? That short?
Yeah, after that first week, the immune system usually clears the virus entirely from the bloodstream. The virus might still be hiding in the testes, or it might have already crossed the placenta, but it is gone from the blood.
Wow. So if our pregnant patient got off the plane, felt sick for 5 days, but waited until day 10 to finally make an appointment at the clinic, we draw her blood, run the PCR, and it comes back completely negative.
Yeah.
But she actually had Zika, and her baby is currently in danger.
Precisely. A negative PCR test outside that narrow 1-week window is clinically meaningless. It does not rule out infection. Now, researchers did discover that the virus is shed in human urine for slightly longer than it remains in the blood, sometimes up to 14 days.
So you test the urine, too?
Right, so standard protocol is to run PCR on both a blood serum sample and a urine sample to try and widen that diagnostic window just a little bit.
Oh.
We can also run PCR on cerebrospinal fluid or amniotic fluid, but amniocentesis carries a risk of inducing miscarriage, so it's not done lightly.
Okay, so our patient is sitting there. Let's say it's day 10. We missed the golden window for the PCR fingerprint test. We have to pivot to the second method, serology. How does serology work?
If PCR is looking for the fingerprint, serology is looking for the footprints left behind after the criminal has fled the scene. It doesn't look for the virus at all. It tests the patient's blood to see if her immune system has manufactured antibodies specifically designed to fight Zika. We look for 2 types, IgM and IgG.
What's the difference between the two?
IgM antibodies are the immune system's first responders, the infantry. They typically become detectable about 4 to 5 days after symptoms start, and they remain in the blood for about 12 weeks before fading away.
And IgG?
IgG antibodies are the long-term memory cells. They show up a little later, maybe around day 8 to 10, but they persist for years, sometimes a lifetime, providing long-term immunity.
So if we test her on day 10 and she has IgM antibodies, we know she was recently infected. Problem solved, right?
I would think so. But this is where the diagnostic landscape turns into an absolute nightmare for clinicians. The clinical texts highlight a massive systemic flaw with serological testing for Zika, which is cross-reactivity with the dengue virus.
Wait, dengue, the bone break fever virus. Why does dengue mess up a Zika test?
Remember at the very beginning of our deep dive when we talked about the flavivirus family? Dengue and Zika are very, very closely related cousins. They share similar genetic code, and structurally, their viral envelopes look incredibly similar to the immune system.
Ah, so the custom puzzle pieces the antibodies are similar to?
Exactly. Because the viruses look so much alike, the antibodies the human body creates to fight them are almost structurally indistinguishable to a standard lab test. If you run a standard serological assay, like an ELISA test, on our patient and it lights up positive for Zika antibodies, you cannot trust it.
Why not? If it says positive, isn't she positive?
Because if she just returned from a tropical endemic area like Brazil or the Caribbean, there's a very high statistical probability that she has been bitten by a mosquito carrying dengue at some point in her life.
Oh, I see.
Right? If she had a mild case of dengue 5 years ago, she still has dengue antibodies in her blood. The Zika test is so imprecise that it will frequently bump into those old dengue antibodies and trigger a false positive.
That is maddening. If the standard antibody test essentially can't tell the difference between Zika and a previous dengue infection, how does a doctor actually make a confident call? Are you just flying blind and guessing?
In a standard clinic, yes, you are flying blind. To actually get a definitive answer, we have to escalate the testing significantly. We have to take the patient's blood serum and physically mail it to a highly specialized, high-security state or federal public health laboratory for a complex, labor-intensive procedure called a plaque reduction neutralization test, or PRNT.
PRNT, plaque reduction neutralization test. That sounds like something out of a biowarfare movie. What exactly are they doing in that lab?
It's fascinating but incredibly tedious biology. They take a petri dish covered in a layer of live, susceptible host cells. In a biosafety cabinet, they take live infectious Zika virus, mix it with the patient's blood serum, and pour it over the cells. They do the same thing in a second dish with live dengue virus and the patient's serum.
Okay, so they are staging a cage match in a petri dish.
Basically, they wait to see what happens. If the patient actually had Zika, her antibodies will aggressively attack and neutralize the live Zika virus in the dish, preventing it from infecting the cell layer, which forms visible plaques or holes in the cell layer.
That's why it's called plaque reduction.
Exactly. By comparing how effectively her serum neutralizes Zika versus how effectively it neutralizes dengue, the specialized lab can finally declare definitively which virus she was actually exposed to.
That sounds incredibly accurate, but also like it takes a tremendous amount of time.
It does. Because you are dealing with live cell cultures and live viruses, a PRNT test can take anywhere from 1 to 3 weeks to yield a result.
1 to 3 weeks. I want to pause and just sit with the psychological weight of that for a moment. We have a 28-year-old pregnant woman sitting in our clinic. We draw her blood and we tell her, you might have a virus that will literally halt the growth of your baby's brain, but the test is confusing, so we are sending your blood to a federal lab. Go home, try to relax, and we will call you in 3 weeks.
It's excruciating.
Those 3 weeks of limbo must be absolute, unmitigated agony.
It is psychological torture for the patient, and it is incredibly difficult for the clinician who have to deliver that news, which brings us directly to the action plan. While that patient is sitting in that agonizing 3-week limbo, or even after the PRNT comes back positive, what tools do we actually have to fight back? What is the clinical management strategy?
This is the part of the medical textbook I always dread reading when it comes to viruses. Because I know what's coming. There's no magical pill, is there?
No. This is perhaps the most difficult reality of the consultation. There is no specific antiviral medication for the Zika virus.
Yeah.
We have nothing we can give her to eradicate the virus from her bloodstream, and we have absolutely nothing that can prevent the virus from crossing the placenta once it's inside her. The standard medical management protocol is entirely supportive.
Supportive care. I want to dig into that term because to a patient, supportive care often sounds like a dismissive clinical way of saying, go home, drink some Sprite, and wait and see. It sounds incredibly passive. What does supportive care actually entail for the acute symptoms?
For a non-pregnant adult, it does sound a bit basic. It involves copious oral fluids to prevent dehydration from the fever, intense rest, and acetaminophen Tylenol to manage the fever and the profound joint pain. But the clinical breakdown emphasizes a massive, non-negotiable warning here. We explicitly and aggressively instruct patients not to take any NSAIDs, no ibuprofen, no aspirin, no naproxen.
Why? If her joints are throbbing, why can't she take Advil?
It circles back to the diagnostic murkiness we just discussed. In those first few days of symptoms, before any tests have come back, we don't know for sure if she has Zika or if she has dengue fever.
Oh, right.
Dengue fever has a much more violent clinical course. It can rapidly cause a severe drop in blood platelets and alter the vascular permeability, leading to dengue, hemorrhagic fever, internal bleeding. NSAIDs, like aspirin and ibuprofen, are blood thinners. They inhibit platelet function.
Oh, wow.
If a patient actually has dengue and we give them high doses of ibuprofen to treat their joint pain, we could inadvertently trigger a catastrophic, potentially fatal internal bleeding event.
So you have to treat every suspected Zika case as if it might be a hemorrhagic dengue case until proven otherwise. So Tylenol only. But let's go back to the pregnancy aspect. If I read these obstetrical management protocols correctly, supportive care in the context of a pregnant Zika patient is not passive at all. It looks highly rigorous. Why is fetal monitoring considered an active form of medical management if we can't cure the virus?
Because in the absence of a chemical cure, information, surveillance, and early intervention are the only clinical weapons we have. The moment a pregnant patient is diagnosed with confirmed or even highly suspected Zika, her prenatal care is radically transformed. We immediately pivot to high-risk obstetric protocols.
So you aren't just waiting.
No, we are actively surveilling the fetus in real time.
What does that surveillance look like?
We initiate a series of detailed, highly targeted fetal ultrasounds every 3 to 4 weeks. Standard pregnancies might only get 1 or 2 ultrasounds total. We are looking meticulously for the earliest warning signs. The technician is carefully measuring the fetal head circumference to detect growth restriction early. They are scanning the brain tissue, looking for those bright white spots that indicate intracranial calcifications. They're assessing the volume of amniotic fluid and the blood flow through the umbilical cord.
What happens if the ultrasound detects something abnormal? If the head is measuring too small at 24 Wits, we still can't give an antiviral.
It initiates a profound multidisciplinary intervention. We immediately bring in maternal-fetal medicine specialists, pediatric neurologists, neonatologists, and infectious disease experts. If abnormalities are seen, we counsel the parents on the option of an amniocentesis to definitively test the amniotic fluid for the virus, allowing them to know for certain if the barrier has been breached.
It's about giving the parents agency in an impossible situation.
Exactly. The active management here is providing the family with the most accurate, real-time medical data possible so they can make deeply personal, informed decisions regarding the continuation of the pregnancy. And, equally importantly, it allows the medical team to prepare.
How so?
If we know a baby with severe congenital Zika syndrome is going to be delivered, we have the neonatal intensive care team scrubbed in and waiting in the delivery room, ready to manage seizures, establish an airway, and begin specialized care the exact second that child is born. We don't want to be caught by surprise.
It is an immense emotional weight for the clinical team and obviously an earth-shattering burden for the family. Because the treatment options are so desperately limited once infection actually occurs, the entire focus of the global public health community has violently shifted toward prevention. How do we stop this virus from ever entering the human body in the first place?
Prevention is multi-pronged, and it is exhausting because it requires flawless vigilance on both a systemic community level and a daily individual level. First and foremost is vector control, mosquito eradication.
Which is hard with the Eads.
Exactly. Because the Aedes aegypti loves urban environments and breeds in tiny pools of water, systemic reduction is incredibly difficult. It requires municipal governments spraying larvicides, but it also requires every single citizen to constantly patrol their own property. You have to dump out the dog bowl, clear the gutters, throw away the old tires, and empty the flower pots every few days.
And on an individual level, if you live in or travel to an endemic area, you have to become obsessed with bug spray.
Obsessed is the right word. It means rigorous, continuous use of EPA-registered insect repellents containing high concentrations of DEET, picaridin, or oil of lemon eucalyptus. It means wearing long sleeves and long pants, even when it's 90 degrees and humid. It means ensuring you only sleep in rooms with robust air conditioning or perfectly intact window screens.
What about the travel precautions? Because our hypothetical patient got infected on a baby moon.
The travel advisories are stark and unequivocal. The CDC and the World Health Organization strongly, emphatically advise pregnant women and women actively attempting to become pregnant to simply not travel to any areas with ongoing Zika outbreaks or high endemic transmission. Full stop.
Just don't go.
Exactly. The risk of irreversible fetal brain damage is too high to justify a vacation. If travel is absolutely unavoidable, say for a family emergency, the adherence to mosquito bite prevention must be literally flawless.
We also have to address the elephant in the room, the sexual transmission aspect, because the vector control only stops the initial bite.
This is where prevention requires intense behavioral changes. Because we know the virus can linger in the immune-privileged sanctuary of the testes for months, the guidelines are strict. Men who travel to endemic areas must use condoms perfectly or abstain from sexual intercourse entirely for a minimum of 3 months after returning home.
Wow, 3 months.
And that applies even if they never felt sick a single day of their trip because of that 80% asymptomatic rate.
And if their partner is pregnant?
If the male partner travels to a Zika zone and returns to a pregnant partner, they must use condoms for the entire duration of the pregnancy. No exceptions. They cannot risk introducing the virus through that backdoor route.
Okay, zooming out from the hospital room and our single patient scenario, how does the medical community at large deal with the threat of this magnitude? The clinical breakdown dedicates significant time to the global radar, the public health response, and importantly, the myths that circulated. Let's start with the massive response. Why did the 2015 outbreak in Brazil suddenly paralyze the world's attention? We have outbreaks of dengue and malaria all the time that barely make the evening news in the West.
Well, it gained such intense global attention because it completely shattered our preconceived biological notions of what an arbovirus was capable of doing. The infectious disease community was used to mosquitoes causing fevers, chills, and liver damage. We were completely unprepared for a mosquito-borne illness, causing a massive synchronized epidemic of severe congenital brain defects.
It's just so visibly tragic.
Right. When those haunting images of Brazilian babies born with microcephaly started flooding international news networks, it induced sheer visceral panic across the globe. By February 2016, the World Health Organization took unprecedented action and declared the Zika outbreak a public health emergency of international concern.
A PHEIC. That is the WHO's absolute highest level of global alarm. That's the same alarm they pulled for COVID-19 and Ebola. What does pulling that alarm actually do?
It acts as a massive global catalyst. It legally and financially mobilizes international funding, accelerates research and development, and forces international health ministries to coordinate their response, share data, and standardize diagnostic protocols. But looking back at that response, one of the most critical public health lessons we learned was identify our own massive blind spots regarding surveillance.
You know, I always look at global health surveillance like a meteorological weather radar system for viruses. We might not have the technology to stop the hurricane from forming over the ocean, but if we have a good radar system, we can track its path, board up the windows, and evacuate the coast. What was our biggest radar blind spot before the 2015 epidemic?
Our critical blind spot was that we only built radar stations to track diseases we already knew were dangerous. Because Zika had historically been considered a mild disease for 70 years, it wasn't listed as a reportable illness in almost any country's health system. We simply weren't tracking it.
Oh, wow.
So when the virus quietly mutated or found its way to the immunologically naive populations of the Americas and started attacking neural progenitor cells, it was allowed to spread silently for months.
So we didn't even see the hurricane on the radar until it was already tearing the roof off the hospital.
Exactly. The lesson the global health community learned the hard way is the absolute necessity of syndromic surveillance.
Syndromic surveillance.
Instead of only looking for specific known viruses, we have to build systems that flag unusual clusters of symptoms or anomalies, like a sudden, unexplained 400% spike in babies born with microcephaly in a specific region, regardless of whether we know what viral agent is causing it yet. We have to search for the anomaly, not just the usual suspects.
Let's transition to some of the myths and FAQs that the clinical texts highlight. Because whenever there is panic and an invisible threat, misinformation spreads infinitely faster than any virus ever could.
Oh, absolutely.
Let's debunk a few of the most pervasive ones. Number 1, can Zika spread person to person through casual contact? Can I get Zika by shaking hands with an infected person, hugging them, or sitting next to them on a crowded bus?
Absolutely. Categorically not. And the virology we discussed earlier perfectly explains why. The virus absolutely requires either a biological vector, the Aedes mosquito, to directly inject it into the bloodstream, or it requires the direct, intimate exchange of very specific bodily fluids, like semen during intercourse or blood during a transfusion.
So no coughing or sneezing transmission.
Right. Zika is not an airborne respiratory virus. It is not transmitted through respiratory droplets like influenza, a cold, or COVID-19. It does not survive on human skin or on inanimate surfaces. Casual contact with an infected person is 100% safe.
Okay, myth number 2. The pharmaceutical companies have a vaccine, but it's either hidden or only available if you pay enough for it at private clinics.
Completely false. As of right now today, there is absolutely no commercially available approved vaccine for the Zika virus anywhere in the world.
I have to ask why, though. We watched the global scientific community sequence and develop multiple highly effective mRNA vaccines for COVID-19 in under a single calendar year. We have known about Zika since 1947, and the massive epidemic was a decade ago. Why is there still no vaccine?
It is a profoundly frustrating intersection of epidemiology and clinical trial economics. It's not that we don't know how to make one. Several vaccine candidates, including mRNA variants, have been developed and have shown excellent safety and immune response in Phase 1 and Phase 2 trials. The problem is Phase 3.
Phase 3 is where you have to prove it actually stops the disease in the real world, right?
Exactly. To prove a vaccine works, you have to inject it into tens of thousands of people, give a placebo to another tens of thousands of people, and then wait to see if the vaccinated group gets infected significantly less often than the placebo group in their daily lives.
Oh, I see the problem.
Right. Because the massive 2015 epidemic burned itself out so quickly and created widespread herd immunity, the baseline transmission rate plummeted. There simply aren't enough active infections happening in a concentrated area right now to statistically prove the vaccine works.
You cannot prove a shield blocks arrows if no one is shooting arrows at the people holding the heels.
Exactly. Getting a vaccine over the final regulatory finish line without an active, raging epidemic to test it in is logistically and economically incredibly difficult.
That is a brutal paradox. We can't approve the defense until the attack happens again. Myth number 3. If a pregnant woman gets infected with Zika, her baby is guaranteed to be born with microcephaly or congenital Zika syndrome.
This is also false. And it is perhaps the most crucial nuance we have to communicate when counseling an anxious patient in the clinic. A Zika infection during pregnancy is an incredibly dangerous event, but it is emphatically not a 100% guarantee of catastrophic congenital defects. The current epidemiological data suggests that if a mother is infected during pregnancy, the actual risk of the fetus developing Zika-associated birth defects is roughly between 5% and 15%.
5% to 15%.
Yes. Now, clinically speaking, a 1 in 10 chance of a severe, life-altering birth defect is a terrifyingly high-risk profile. It is entirely unacceptable, which is why our prevention guidelines and obstetrical monitoring are so aggressive. But it is not an absolute certainty.
So there's hope.
Yes. Even with a confirmed maternal infection, there is still an 85% to 95% mathematical probability that the virus will not breach the placenta effectively or won't cause severe damage, and the baby will be born entirely healthy. We have to provide that data to parents so they aren't consumed by absolute despair.
Finally, myth number 4. And this is the one that gets tourists into trouble. The big 2015 epidemic is over, it's out of the news cycle, so travelers to the Caribbean or South America don't really need to worry about bug spray anymore.
That is dangerously, wildly false. While the massive continent-spanning epidemic wave has indeed passed, the virus did not pack up and leave. It is now deeply entrenched and endemic in the local mosquito populations across popular tourist destinations in the Caribbean, Central America, South America, and parts of Asia.
So it's still out there.
If you are a traveler from a non-endemic area who has never been exposed, you remain entirely 100% susceptible. The statistical risk of catching it is lower today than it was at the peak in 2016, but the virus is absolutely still there hunting for a host. The precautions remain mandatory.
Okay, we have covered an immense, staggering amount of scientific ground today. We've tracked this microscopic pathogen from its obscure discovery in a Ugandan forest canopy in 1947 through the complex mechanics of how it hijacks our cells all the way to its explosive, tragic arrival on the global stage. Let's bring this full circle and synthesize the absolute most important take-home messages for our listeners.
If you distill everything we've discussed into a core clinical foundation, there are 4 key pillars to remember. First, respect the unique, unprecedented transmission profile. Zika is an arbovirus driven by the highly adapted, urban, daytime-biting Aedes mosquito, but it possesses the terrifying, anomalous ability to circumvent standard rules and be transmitted sexually via the testes and vertically from mother to fetus across the placental barrier.
Got it. And second, the severe complications are entirely defined by the virus's specific neurotropism. It carries the master key for neural progenitor cells. In a developing fetus, this leads to the cellular massacre that halts brain development, resulting in microcephaly and the devastating spectrum of congenital Zika syndrome. In adults, the immune system's confused response to the virus can trigger the ascending autoimmune paralysis of Guillain-Barré syndrome.
Third, diagnostic vigilance is essential, but you have to understand its severe limitations. Relying purely on standard antibody serology in endemic regions is a clinical trap due to massive cross-reactivity with the dengue virus. To get a true answer, you must utilize highly specific PCR testing during the narrow early window of viremia or rely on specialized time-consuming plaque reduction neutralization tests later on.
And finally, because we do not have a vaccine and we do not have a specialized antiviral medication, our only truly effective medical intervention is rigorous, unyielding prevention. Vector control of standing water, aggressive use of DEET, strict travel avoidance for pregnant women, and the use of barrier methods to stop sexual transmission are absolutely non-negotiable.
Ultimately, understanding these viral mechanics, how the virus physically spreads, how it biochemically attacks our cells, and how our immune system responds, empowers clinicians to provide sharper, more compassionate care. And it empowers you, the listener, to navigate sensationalized global health news with a critical eye and to make scientifically sound, safer choices when you travel without succumbing to blind panic.
We started this deep dive in a clinic room with a pregnant patient staring down a terrifying, murky diagnostic landscape. And while modern science has given us the tools to peer into the microscope and understand the exact mechanisms of the threat she faces, the clinical breakdown leaves us with a macro reality that isn't entirely comforting. The massive, tragic epidemic of 2015 and 2016 may have slowly faded from the front pages of our newspapers, replaced by other global crises, but the virus hasn't vanished. It is quietly dormant. It is circulating right now at baseline levels in the endemic regions, hiding in the mosquito population.
Right.
But I want you to consider this final thought before we go. As climate change continues to alter global temperatures, warming up new latitudes and shifting rainfall patterns, the hospitable geographical habitat of the Aedes aegypti mosquito is actively expanding further north and further south into completely immunologically naive populations. At the same time, global travel continues to shrink the distance between a dense tropical forest and a bustling modern metropolis to the length of a single commercial flight. The underlying biological mechanics of this neurotropic virus, its ability to hide in the testes, its ability to cross the placenta, none of that has changed.
It really hasn't.
So the question isn't whether Zika will disappear. The biology tells us it won't. The real question we have to ask ourselves as a global community is, how long is it before the perfect storm aligns again and this virus finds an entirely new, unprotected population to test our scientific and public health preparedness all over again?
It's a deeply sobering question.
Yeah.
And it's exactly why global health surveillance, that vital meteorological radar for disease, can never truly sleep.
The murky diagnostic waters remain. It's up to us to keep navigating them. Thank you for listening to The Deep Dive.